PhD in medicine, and after I finished this, I fell in love with the pharmacy, especially clinical pharmacy, and it was one of the highlights at that time, and I really liked it so much. So I graduated from University of Tennessee Health Science Center. The second time was PharmD in 2000, and I've been on faculty before that as in medicine, and then I just went into an office between the two colleges. So my resident insisted that we have two logos, one for the pharmacy and one for the medicine. So just the team insisted to do that. Okay, today's talk is going to be, this is the new building for pharmacy school. We are so proud of it. The building is designed that we have all the windows for the faculty to be looked at from the inside. So by this way, our dean will come and just look from the window. She can check out who's there in their office. So it's a very interesting concept, but we are so proud of it.
دكتورة سحر ممكن بس الميكروفون الصوت فويس raise your voice please.
Okay, very good. Okay. No problem. Okay, well, what we're going to talk about today is the pharmacist in the disease management. And our goal now in the U.S. is the eradication of hepatitis C. So our goal in 2020, 4 years from now, we're going to have nobody in the U.S. has hep C. I was really very, very upset when I found that Egypt won the first place in the whole world to have hep C. And I decided to come and share with you the models that we have to eradicate hepatitis C. As I said, our objective today is going to be just looking at what are the efforts to eradicate this system, and also from the more is the economic impact of this pandemic. So hepatitis C affects more than 170 million persons worldwide, and there's about 350,000 die every year from this. And liver disease is number one indication for the liver transplantation. There's a static. Is that what you can hear? I hear statics. Statics when I give it full.
static.
Yeah. Can you hear these statics? Yeah. Okay, we'll try to do our best here. For the number one, hepatocellular carcinoma as well. Okay, if we look at the map in 2010, we can see that Egypt, somewhere in the map, with the high numbers, along with Nigeria, Pakistan, China, and India. And Italy was just a little drop there, and that was 2010 statistics that was published. Meaning that when they give you the statistics this time, then this means that they had some time. So this is the statistics in 2010. Then we look at 2015. Egypt escalated to be number one in the whole world, and then along with Italy and Pakistan. These are the things that really bothers me. Why U.S. we are eradicating the Hep C while Egypt is number one for Hep C? I really thought maybe this is a wrong number of statistics. Maybe they are calculating everything, the hepatitis A and B and C, but not C. I could not believe that this is what the case was. So we're going to go over the drugs that we have and the new drug that we got off the market just 2 weeks ago. So by this way you can be looking out for this type of drugs. So who's at risk for hepatitis C? Healthcare professionals is number one because of the needle stick and needle stick between patients to professional or patient to patient. Blood transfusion, hemodialysis is the one, the numbers are the associated with Hep C the most in Egypt, the way I read. So the problem also with the hemodialysis is the disinfection practice, failure in medication and preparation. Sometimes the way that they are not taking care of how they are preparing their medication. One of the interesting slides that I saw in the morning talk was the way the person was handling the vaccine. It is absolutely wrong. You cannot carry the vaccine the way it was in the picture. And I am certified by the APHA for immunization and for also medication therapy management. And if I were to see one of my students carrying the vial this way that both looked in the morning, can be, can get out of the pharmacy only the next way. So just make sure that you practice it properly, not the same way as the picture shows. Do you do that here in Egypt? Do you give immunization?
Yeah.
No. Okay. Do you give immunization in Egypt? Pharmacists immunize people?
No.
Well, this is a big thing for us in the U.S. Every pharmacist before they graduate, you must know how to do the immunization. Otherwise, they will not graduate. Okay? A body piercing, tattoo, cocaine abuse, IV drug abuser, because we have a problem always with the IV drug abuser because they have poor veins and most of the time they are damaged. Piercing, all of these issues that, wherever needle is. One of the interesting things that one of the patients came to us last week was she went to the hairdresser, and the hairdresser does like the African American people in the U.S., they do the braiding of the hair, and they do it with needle, so they can weave the hair in such way that they can, have this shape. But the problem is this needle can hit and get blood broke and transfer to another person. So that's one of the new mode of transmission of the disease. Prisoners, homeless, people in any institutionalized practice, they always can transmit Hep C easily. Transplant organs, one of the things that we don't have it anymore in the U.S., but it is listed as worldwide mode of transmission of the disease. Household exposure. One of the things that is very important when we talk with the patient and their family. When a patient comes to our pharmacy or our practice, wherever it is, and has Hep C, we have to counsel the family. Absolutely, we have to screen all the family. The patient may not even get the medication. We will not give the prescription without screening all the family members. And make sure that they are educated very well, that they have to have the toothbrushes away from each other, the hair combs. Any of these things that are related to the patient has to be isolated from the other members of the family. Imagine sometimes patients, they are infected and they are transmitting this to everyone in the family without knowing that he or she is having the disease. Not to mention that females also, when they have the disease, they transmit it to their new children. So this is, it's so sad to do that. Which is the brinker transmission. We talked about the needles, contaminated surfaces. One of the things that we know about Hep C, that the virus can stay alive on hard, dry surfaces for a long time. Meaning that if I were to have a cut in my hand, my finger, and I put the blood drop here, and I go to the U.S., having my life there, and here this blood drop has Hep C. It's going to stay here. In 2003, we were saying that it's going to stay here for 3 days. Now it is for 6 days. We can still detect the virus into this blood drop dry surface. Room temperature and -20 is going to be the same activity as it was in the beginning of the blood clot. So imagine that how bad it is. Even a patient in a hemodialysis bed, if they have a drop there, even if it can be a fluid that you cannot see, then they sneeze with strong sneeze, they have like blood came along with their sneeze, it can stay in the bed. It can stay in the bed structure. It doesn't have to be the sheet only. It's staying there. So it's really, really dangerous. More so, it can stay for 12 days. We can detect it with the light. This is how dangerous it is. Okay, now we took advantage of this now in the United States for screening, meaning that it is obligatory on every primary care in the U.S. to collect blood samples from every patient for whatever reason that we are collecting, but it has to have another blood sample for Hep C. This is our first step of eradicating the disease. We want to know who has Hep C, and we start with there, and then we start with So we run this test and just keep going with it. One of the problems with patients that they are having the Hep C is the clinical presentation. Patients is fatigue, malaise, nausea, vomiting, anorexia, jaundice, hepatomegaly, dark urine, yellow stool. Of course, they feel that the liver is aching. More so is the encephalopathy that these patients are always having throughout their life with this disease. One of the side effects of this, or one of the presentation, is the patient is always angry. They are on the edge all the time. They lose their friends. They lose their family because of their anger. I was driving with the driver the other day, and I saw two people fighting with each other. I don't know what the fight was, but I said, "Oh, maybe they have Hep C and they start fighting with each other." If the ratio in Egypt, every 4 people they have 1 person has Hep C. This is what the WHO calculates, that every 4 people in Egypt, they have 1 person has Hep C. It's just staggering. I could not believe that when they were presented. So, this now it is the new cheap assay that we do with patients. We use the French technology for doing this type of screening in the U.S. Part of the diagnosis for Hep C, we have to look at if there is any kind of fibrosis and all of this good stuff. Hep C, we have genotype 1, 2, 3, 4, 5, and 6. I know that you are interested in genotype 4. In the U.S., we've been focusing on genotype 1 and 3 because these are the majority of our patients there. So 1 to 6 are distributed worldwide. The African American, in Africa we have the genotype 1, 2, 4, and 5. Asia is the 3 to 6, 3 and 6 actually, and you can see the statistics. Of course, most of my presentations are focused on treating genotype 1 and 3 because they are the most important category for the United States. Looking at the genotyping for all around the world, you can see Egypt, they have the majority as type 4 and just a little bit from the other types. So it's very important that you know what is the genotype of the patient that you are dealing with. Now, this is the way we are looking at it. We are saying, okay, if we do screening, and that will do with ELISA, antibodies, all of this list of the screening. That will cost that much, about $3,000. Now, if we intervene with the medication, okay, that will cost us about $25,000, $26,000 to treat this patient. Now, if we were not to do the second part of the therapy, then the patient is going to go to transplantation, and that will cost us about $500,000 per patient. So which one is cheaper for us? As a government, we should be really going towards this side. We have to look who has Hep C, who can treat, and then so we can avoid going to transplantation. This is really a very important part. This is the strategy that we are going with. So if we do screening, we know who has the disease, then we can give the medication. Between me arriving to Egypt until yesterday, it's only 2 days, I met 2 people, by accident, by poor accident, and they have Hep C. And one of them, I told him, okay, so which protocol do you have? He said, what do you mean, which protocol? He said, I went to the doctor, and they sent me to the, I think like a government agent doctor, and he told him, okay, here's your prescription, and you stay on it for 48 weeks. Wait. How many times did you do your blood work so far? He said, none. I said, what? How could they pay for you? How could they dispense for you 48 weeks of medication? What will happen if it doesn't work for you? You are taking the medication of somebody else. You see, this is unfair. They have to test it, because not a single patient in the U.S. can start or take the medication more than a week or 2 without checking to see if the medication is working or not. How could we put the patient for all this time? This is to us in the U.S. to be considered a crime and waste of resources. So most important that you have to check the response to this patient to this medication that you are giving, viral load, and also the liver, status. If the liver status improved after the first week, okay, we are in the good way. 2 weeks after, we have to look at the little piece of the viral load. If it works, good. We're going to put the patient for 12 weeks. Only 12 weeks, and then we check. After the 12 weeks, if we have well-log decrease, then we are okay. This is it. Sometimes patients, after the 12 weeks, we have 0 after. Then okay, we are good. Why should the patient stay for 48 weeks without knowing that they already finished the treatment or not, or eradicated the virus or not? So this is a missing link here, and I think we should work on it because it is cheap to do the testing. Now with the French way, it's even cheaper than $3,000. And we're talking, of course, about the full price. I'm sure between governments they have, much more cheaper prices. How to solve the problem? Talk about the pathophysiology of the disease, and then the new discovery of the drugs. So public screening is very important, and patient education and the prevention strategies. So here is the virus, and these are the things that we know about this virus. It gets in, and then the good thing about the Hep C virus, it does not integrate into the nuclear DNA as the HIV. So by this way, we can eradicate this. Patients that they have co-infection with HIV and Hep C, we always stop the treatment. We don't start them for HIV treatment. We have to start them with Hep C because it's 12 weeks. 12 weeks are disclaimed from Hep C, then we can treat for HIV after that. It's no problem. But to put it and just wish good luck, this is unfair. So this is the picture we are always looking at it as a scientist, and we look at it as, okay, here is the RNA going to come out, and it's going to manipulate the system for to make copies of their proteins, so we can make a new capsule for the new virus, and also the stuff of the RNA. So we use the same strategy that we use in treating HIV, which is the protease inhibition. What it is that it's a simple, easy way to learn about it, is that the RNA, when it suppresses one piece of protein, and this one piece of protein is going to be attacked with the proteases specific for this, it's going to cut it into pieces. This single piece of protein is not active. If it gets cut, then it's going to be active, it's going to make a new capsule for the new virus. So if I were to prevent the break, if I inhibit this protease, it's going to cut it, then I'm in good shape. Okay? So that was the strategy for treating the HIV virus. Now we are using it with the Hep C. So this is a great intervention, really, and we are so pleased about it. Once we start to see what are these proteins that we can inhibit and prevent the virus from propagation, is became very, very important. Disease progression is very important to them. You can see how bad it is with the liver and things. Sometimes the liver, when we look at the patients when they come in surgery, the liver is that much. That's just a little piece there because of the cirrhosis and all these problems with it. These are the things, parameters that we are looking for. Sustained viral response, and these are either 12 or 24 weeks after stopping the therapy. That's what we are looking for. So we want to make sure after the patient finishes the 12-week therapy and we have zero viral load, we have to still continue to check this patient that it is clean. The problem with Hep C is no. The problem with Hep C doesn't sit in the liver only. The problem with Hep C stays in the base of the brain and the synovial cells in the knee. Most of the time, patients present as having diabetes or they are having arthritis. So these patients that they have diabetes or patients have arthritis, we have to check them for Hep C. So these are the strategies that we are going with to make sure that we eradicate the virus. So the null hypothesis, the non-response, just lack of the true log decline. Then we don't have any response. So if we don't have true log decline in the number of the RNA, to stop the treatment, there is no need to continue with it because the side effects of the drugs and all of these things, and of course the cost of the drug. So these are really what we are looking for. This is the 12 weeks, and also now if the patient responds slowly, and of course, as you know about the genetic response for this type of virus, we have the CC allele or the LL or the CL alleles. So the patients that we have the CC alleles are the ones that they are responding very well to the treatment, and they always have even shorter than the 12 weeks to have eradication completely. So these are the new actually way of thinking, is to screen the patient and see the genotyping of these patients before we start treatment. Because the ones that they are going to be sensitive to the drug, okay, we just give them a very short treatment and we look for it and we are done with it. But to give them all the 48 weeks, this is just insane. Okay. Now this is what we used to use a long time ago. 2003, after I finished my education in pharmacy in 2000, I developed these programs for pharmacy. First one was immunization, and we did it all around the U.S. The second one was MTM, and we finished that. MTM is not an issue anymore with pharmacy. MTM is like studying pharmacology in class. It's not something that we have to reinvent it. It's just a class. Third one that I worked with was the Hep C. I developed what we call it the office practice model, meaning for every physician that they are having a group of patients that they have Hep C, then they get these patients about once a week or once a month, and the clinical pharmacist will go and talk with these patients. make sure that we convince the patient to stick and adhere with the treatment. Treatment with interferon and ribavirin was really, really bad. Patients, they were having all kinds of problems and the pain, and just very absolutely was painful for them. But we were able to succeed with that, and we were able to increase the adherence with these patients, and of course, to translate in the American culture by how much money we make. So after 1 year of working with 350 patients with Hep C, with this poor treatment that we had 60% success rate with it, we were able to make $3 million. Of course, if I said that for you, it's not a big deal, but it's a big deal in the U.S. I got a lot of awards about it and things like that. So now, the era of the interferon and ribavirin is no longer our concern anymore. These are the clinical trials. These are the slides that we have presented to the pharmacy, graduate pharmacy, that they're working on the PhD and things. So I'm just going to skim through the clinical trials because this is their part of research. So we're just going to go through it. Of course, these are the list of the side effects of the interferon therapy, and you can see the depression, the emotional liability, and all of these side effects. Every time the patient is on the interferon or ribavirin, we have to check about their emotion. We have to check this every 3 weeks. So patient gets any drugs of this category, we have to get them back to the clinic, talk to them. It's very interesting, the questions that we ask them. We ask them, do you want to kill yourself? Do you want to kill somebody else? Do you have any desire that you want to kill someone? Sometimes they say yes. Then, okay. Then we have to stop the treatment. So we don't want this to happen. So this is the way we deal with this patient. Of course, we have to look for the blood work and make sure that they are able to tolerate the medication. So I would say let's keep going. This is the first 2 drugs that became long time ago. I was still in pharmacy school some time ago, and then they were saying, oh, the B word and the T word. I tell the patient, what are you taking? Oh, I'm on the T word. Okay, toliptavir or procipravir. This is in addition to the interferon and the ribavirin at that time. So it was showing little improvement, from 60% improvement to 65 or 70%. We were so happy about these 2 little drugs here. And these drugs are the ones that inhibit the spindle filaments that after the RNA is making a copy, then it has to have the spindle to make it. So each one of them can make a new one. So these were the mechanism of action of these drugs. But it came along with the same side effects that we had before. Still the anemia, the neutropenia, the vomiting, all of these things, because we are adding it to the ribavirin and the interferon. Outcome was great at that time, but it was not good enough. We continue working. In 2005, out of a sudden, we had no single patient comes with any prescription for Hep C, for this drug or anything, because all of these patients were pulled to the new drugs that we have now. So I used to see them with the American Liver Foundation support group. I am on the board for American Liver Foundation, and we are always looking for the research that is qualified for funding. So we can, by this way, we encourage the scientists who are trying to work on these issues. So come to the era of Olysio. Again, it's one of the first protein inhibitors of the protease. So we said, okay, great, we're on the right track. That increased the success rate from 70% to 80%. But still our target is 100%, right? So this was not good enough. So it just was working on just only one protease inhibitor, and that was not strong enough. Then we said, okay, let's go full eradication of this all protein. So one time we had about 6 drugs in one trial, and all of them just inhibit all the proteases of the virus. But the side effects of it was horrible, and the patient could not tolerate that. So we stopped that. It never came as a drug, but one of the clinical trials that we were doing at that time. That was 2006 at that time. Keep going with this. The Olesio, we had the photosensitivity, the rash. Rash was bad. The Stevens-Johnson syndrome rash. It was like side effects and anemia. It was not an easy one. It showed an effect, which is 80%. Happy about that, but you still for the 100%. Comes to Valdi. Of course, we know these names, the names of the drugs, meaning something. And that was a scientist, his daughter, her name was Sophia, and he called it after Sovaldi. Sovaldi really, when it comes on the market, then we start to see better effect in terms of the side effects that the patient experiences. So we decided to say, okay, forget about the Olesio, forget about anything else, let's go with Sovaldi. And we started to look at this great drug that came. Still, we don't get 100%, only getting 85%. So, it's again what kind of protein that this drug will have in the stomach. Of course, we got the atomic trial, and this is what we presented to the graduate students so that we will see what not to do, right? So, by this way, we can think about something better than that. Of course, these clinical trials, we have a lot of patients all around the world, and this one of the trials that was in India and China. So we had a good amount of patients to recruit. I was wondering, do you have any clinical trials that of these drugs happen here for Egypt? Anybody know about that? You do?
And we have many trials underway since Sovaldi came into the Egyptian market.
Okay, excellent. And then it's on the postponed trial, and then the side effects of Sovaldi. We started to have only the fatigue, headache, and then neutropenia, and the anemia and the nausea. So what we are trying to do here is to decrease this box. We just want to decrease the side effects. Because once we decrease the side effects, we have better compliance. So this is the most important thing that we always find. So we started to say, okay, here's a drug, work on this protease, and here's another one, work on another protease. Let's combine. So we started the era of combining drugs out of carbon. So carboni is one of the drugs that, as far as I know, that is tried here in Egypt, and it is a recommendation now. However, they advise it has to be combined with the interferon still. But the combination with any of these drugs with interferon, our country did not have. So carboni was great, but it's not that great because only got to 90% success rate. However, unfortunately, whatever we hear in the States, we don't hear about the trials in any other country. The most important thing is type 1, type 2 are the ones. Type 3, of course, is easy to tackle. Even with the interferon, it was easy to finish with it. But, of course, the side effects, still we have to get a new drug. We got the drug 4 weeks ago. So, here's the mechanism of action. It's another 2 proteases to inhibit. And then, here's the clinical trials and the numbers and things. Excellent. Looks great. But still we don't get the 100%. Young trials, we worked with it in our campus, and it was one of the trials that we worked with our patients. Side effects of carboni, we started to increase. But the most important thing is the headache. patients were complaining about the headache very much in the diarrhea. Because diarrhea led to dehydration and then hospitalization. Once the patient goes to the hospital for any of the side effects of the drugs, it's a big red flag. Because we don't want to accept any side effects of any drug to make the patient go to the hospital, because hospitals are costly and we don't want them to reach it. So, comes the era, and then also we look at the side effects and, of course, the drug interaction with them. And the amino acid was one of the big things that the patient wants to have. And we have to make sure that the counseling with the pharmacist is very, very important. In my practice, I work with a specialty pharmacy of Walgreens. Walgreens is one of the big drug pharmacy in the U.S. Now it is having a collaboration with Boots in Europe. Now it is Walgreens/Boots. Clinical pharmacy is not a word anymore. We have only pharmacy as the word clinical. Just got dropped because everybody's a clinical pharmacist now. Don't have anybody graduate with the clinical pharmacy as a different field than anything else. The next, we have now specialty pharmacy. Specialty pharmacy are the most complicated cases of patients. These are what the pharmacist deal with. So what we do is that I go in the morning and attend all the rounds in the hospital and identify which patient is going to be getting out of the hospital. But I'm not dealing with diabetes that they have diabetes or COPD. These are things easy for the clinical pharmacist to deal with in the hospital and after the hospitalization. When I see that in the next talk I have. But I look for these patients. I look for the Hep C patients, the HIV patients, oncology patients. Especially the oncology patients, they are always depressed, of course. They are resisting or denying that they are having the disease, and these are the ones that we work very, very hard with. So these patients, we have a system to collect data about them called SORA, and SORA is one of the things for documentation. Every time we talk to the patient, we have to write what happened in the talk. Even the patient called at 3 o'clock. Of course, the system will collect at 3 o'clock, 4 o'clock. But every time I talk to the patient, it has to be reported. Some drugs we have in specialty pharmacies, like oncology drugs, we are, managed to, we have to report the FDA, things like that. So our reporting has to be exactly the RAINS program, any of these programs that we have to report on.
Dr. Sahar?
Yes.
5 minutes, is your time?
Okay. So, come to the era called Vekir. Okay, this, of course, the closest name to it is Shakir. And the scientist said, I was watching TV with Shakira, and I thought about the combination of other drugs. So, we told them, no, you cannot call Shakira for a drug, so we call it Vekir. So this Vakira is Vakira pack in here, and what it is the patient is gonna just spoon every day one of the recipes like this, and he's gonna take these drugs. Okay? So Vakira is one of the drugs that have a good combination, but it has 1, 2, 3, 4 drugs. So the patient has to take 4 drugs. So the price of this package was very expensive per year. Okay, so one of the things, of course, globally, if we are successful with a drug with one genotype, we try to apply it to the other genotype. So we try to apply this type here, but it was expensive because of all the combinations that we had. So we started to look for cheaper one. Cheaper one is to take one of the drugs, and that would be the new drug that we have. I listed here all the side effects and all the drug adjustment that we need to do with these patients, and these are things I can leave it for you, and these are the things that we always look for when we look at the patient, drug interaction. Of course, I understand your system here. You don't have a good collection of the patient's medication that you are taking, because when I go to the pharmacy, unfortunately, the pharmacist asks me, what do I want? And I want the pharmacist to tell me what I should take as a person. As, you know, I have this, what do you recommend? Oh, I recommend this. I should be confident to recommend this. But our system does not allow any patient to have any drug without being documented in their profile. By this way, it's easy for us to detect any drug action or any problem that can arise. So all of these things are contraindications. With all the drugs, of course, herbal medication patients are like to take herbal medications a lot in the U.S. and trying to think that, okay, I can boost the treatment further. Okay, the last era showed a few weeks ago, and we started to get, this is the bacteria pack that I was talking to you about, and this is the duration of treatment. 24 is when we have cirrhosis. We have cirrhosis, then okay, go with 24. You ask the patient, do you have cirrhosis? I don't know. Nobody told me. Okay, why should we put the patient for 24 weeks if it is 12 weeks good enough? So, genotype 4, what do we have for it? Again, we're going to, instead of targeting so many proteins like this one here, we started to have a new one, which is the technical. This is for type 3, genotype 3. It's only one drug now that we have for type 3, and it's easy to tackle, but now this is for type 4. This is specific to type 4. And the presentation for this drug is not happening, did not happen yet, but it is on the market for type 4. And this is, as you can see, the difference between this and the Kira. We are missing one of the drugs. Actually, we are missing 2 drugs in here. This way, it's cheaper, yet we can take care of it. We have a lot of patients in the U.S. that they have type 4, and they are the pockets of druggy population in the U.S., and we are trying to make sure that we are going along with the goals that we have for eradication of epilepsy. So, this again is a mechanism of action. New clinical trial in the way to look at the cirrhosis and the other things, and these are the most important things that we are focusing on. Again, this is mechanism of action. We can add ribavirin if we have cirrhosis. Only ribavirin, not enantiron. We don't have enantiron anymore in the regimen of anybody. Success rate is 99%. That's what we are looking for. Okay? Solving the problem, public screening. We have to screen the public. These are what is the recommendation for every agency? The CDC, the AARP, the NIH, all of them. Each organization has goals and plans for what we're going to do to eradicate Hep C completely from the society. Anything, any Hep C, 1, 2, 3, 4, anything we have in the U.S., we have to make sure that the U.S. is clean from Hep C by 2022. So, patient education is very important. That put the burden on the pharmacist to do that and make sure that we are educating the patient. No patient comes out of the pharmacy without education. Actually, the rules of the board, if the inspector is so the patient pick up the medication and leave without the pharmacist talking to this patient, that pharmacist can lose the license, and that's really very bad. You go to pay hundreds of thousands of dollars to go through the education, and because you did not cancel one patient and lose your license is not an easy feeling. Patient education is very, very good. Make sure that the patient go for the blood work. Make sure that you look at the blood work with the patient. Tell them, okay, that's why the doctor is going to have you to continue for 24 weeks. Now you can rest assured that's only the 12 weeks. You are done, ready to go. So these are what, patient education is the most I think that's the most important things in my presentation, and I really need that to thank Jeff. He's my resident. He works with the Hep C patients, worked very well with them, and we were fighting about the presentation. He kept putting for me clinical trials and the reading the slides, and then, no, I'm going to issue. It is only type 4. Why should we do that? He insisted that I had to wear this suit to be closer to the color for the school, and just put all the other clinical trials for anybody.
Thank you, Dr. Sahar, for this presentation.
Thank you.
And thank you very much.
I'd like to take any questions you have.
Do you have any question?
I'd like to have any discussion you'd like to have, because I understand you have a huge problem here. Yes.
I'd like to know how sensitive the severity is to genotype 4.
It's not very sensitive.
Effective.
It's not very effective.
It's not.
It is not. You have to, before you take any drug and give it to the public, you have to make sure about the success rate for 4 is not strong enough. I would say it was in the range between 60-70% success. Not every patient is going to be cured like that.
Do you know that now it's recommended for the public by the government?
Well, government has to go to the next step and see technically.
So they're supposed to go through to the Diakera?
No, not the care, the technically. Technically is a new one.
The last one.
The last one. Technically, you just came to know about it. I will leave the information about technically for anybody's interested. I have a huge bag. I have to get rid of it before I leave.
How much is the cost?
Cost is less than Bacteria and less than Sovaldi. Less than Sovaldi, because these proteins are very sensitive to type 4s, yet they are very easy to make. So they are even cheaper than Hargon. Not to mention, any patient to be on these drugs has to be screened properly to make sure about their genotype, to make sure about the successful, and make sure that you have them to be checked out after 2 weeks of taking the treatment. Don't leave them for 48 weeks. This is waste of resources. I'm sure the government paid so much money for that, and it's unfair. I know it's free, but there's no need for abusing the free. Anybody has discussion about that? Anybody dealing with Hep C patients? Anybody dealing with Hep C patients?
Okay, so if you allow me to join the discussion, what is have been presented from Dr. Sahar's side is really very, very important because we are taking care of a lot of patients and we are involved in many routine work. We haven't any time or any effort to concentrate in hepatitis C or hepatitis B virus infection, which is completely a very main problem among our patients. If you allowed me to speak in Arabic, يعني احنا بنقول ايه العيان اللي عنده هepatitis C وكده مالناش دعوه، اجري على معهد الكبد، احنا مالناش دعوه بيك خالص. واحنا في حين ان احنا ده بيوقف علاج الكيموثيرابي، بيأخر العملية وبينفكت ذا هوسبيتال وبيدرين اور ريسورسز في اتجاه احنا مش عارفين نغطيه. يعني لما العيان احنا عارفين ومتأكدين انه عنده هيباتيتس سي ومش هتاخد العلاج وهي بريست، والبريست هيبقى ادفانسد ستيج ونروح نديلها علاجات بآلافات الجنيهات لاننا اخرناها في الايرلي ستيج، which is very dangerous problem. We are doing a vicious circle يعني for us and our patient. وعايزة أختصر في كلمة واحدة عشان ما أضيعش وقتكم. The Bethesda Institute, which is National Institute of Health in NCI في أمريكا، في recommendation how to prepare your patient for chemotherapy بوضوح شنيع ask for hepatitis C and B. If they have a history of hepatitis C and B, either you do vaccination or you follow up very meticulous. ما نستناش لما الكيموثيرابي يعمل severe immunosuppression, neutropenia and flare up of the virus. فإحنا مفروض في معهد الأورام we have the responsibility to build up a study or a protocol that how we can detect our patient or the relative and how we can offer them a proper service.
Very well. The other thing that we are trying to do as a community pharmacy is that screening the public, meaning that because any patient has diabetes can go to any pharmacy and get checked for their blood sugar, right? One of the things that we know that every patient has Hep C has also diabetes, but the other